So good morning, doctors and also medical students from all around the world. I'm Dr. Aurora Tam from Department of Otorhinolaryngology, Head and Neck Surgery, Prince of Wales Hospital, CUHK. And today I would like to talk about hearing loss and dementia, a prospective correlational epidemiological study, a burden to be addressed. So why hearing loss and dementia? So actually hearing loss has been shown to be independently associated with dementia, and multiple longitudinal cohort study actually have controlled various confounding factors like age, gender, education, and also hypertension, and still able to find a independent association. And in fact, it has been shown that the degree of hearing loss positively associated with the risk of dementia. So if the patient is found to have mild hearing loss, he has 2 times higher risk, moderate 3 times, and even up to 5 times in severe hearing loss. And for the degree of dementia, a hearing loss is also positively associated with the faster rate of cognitive decline. So the situation in Hong Kong, there are around 2% of Hong Kong population with hearing loss, and obviously the prevalence increases with age. By the time we reach 70 years old, there's already more than 60% of the population having hearing loss. And it has been shown that around 4% of our population has dementia, and the prevalence doubles with every 5 years increments of age. So with advancement of medical technology and also improvement in healthcare system, we are expecting a longer life expectancy in Hong Kong. Just 2 years ago, for male, it's 83 years old, and for female, it's 88 years old expected age. So the prospective increase of share in elderly population in Hong Kong is expected to be more than 30% by 2038. So we can imagine the huge socioeconomical and also the care burden it is causing to our society. And the proposed pathophysiology of hearing loss, how it led to dementia, could be due to the sensory deficiency and leading to the efferentation and also the atrophy of auditory system and subsequent cortical reorganization and memory and cognitive and processing decline. And in fact, hearing loss has been reported in Lancet 2020 that it is the largest modifiable risk factor against dementia. So if we do something about hearing loss, we might be able to relieve the burden of dementia. So there's something special about our population. So in Chinese elderly, they're less concerned of hearing loss compared to the Western country. So it could be attributed to the phonological structure of Cantonese language, where we tend to speak in a low frequency pitch variation, whereas hearing loss previous cues usually affect high frequency. And in Chinese culture, elderly speaking with a relatively louder voice or have hearing loss was considered as part of their own character. And we are accustomed to being situated in some high ambience noise environment, and they're in general quite reluctant to wear hearing aids. So these combinations of factors actually makes Chinese elderly less concerned of hearing loss. So as for depression, around 10 to 15% of our population was found, elderly population was found to have depression. And it has been shown previously that depression and hearing loss has an independent association. So our study was to determine the prevalence of underdiagnosed neurocognitive degeneration and depression in older adults with hearing loss in Hong Kong, and to see if there's correlation of hearing loss on dementia and depression. And it is a prospective epidemiological study that has been ongoing since May last year. And we're still recruiting patients through our cluster ENT clinic. And we recruit patients that are equal or older than 60 years old with subjective hearing loss and exclude those that has pre-existing dementia. A brief introduction on our cluster ENT nursing clinic. So before the introduction of the nursing clinic, the patient actually needs to take more than 1.5 years before they can have a formal audiological assessment, and another 1.5 years before the formal doctor's assessment. So much longer time before they can actually get a hearing aid. But after we introduce the nursing clinic, so the patient is usually seen within 3 months by our trained nurse. and then they get a PTA assessment and a much faster time before they could get a hearing aid if they are found to have a significant hearing loss. So a much faster presentation to prescription time for hearing loss. And so obviously we assessed hearing with PTA, and for neurocognitive impairment, we use the Hong Kong Marker Score and also AD8. And for depression screening, we use PHQ-9. And those patients that were found to have hearing loss greater than 40 decibel, then we will prescribe hearing aid for them. And those that were screened to have neurocognitive impairment or major depression, they will be referred to the Department of Psychiatry or Geriatrics. So we calculated the AC average 1, 2, and 4,000 hertz of the better hearing thresholds, and the hearing loss severity was graded as follows. As for neurocognitive assessment, we use the Hong Kong Markers score to assess, which actually takes account into visual spatial function, naming, memory, attention, etc., giving us a total score of 30. And we also take account into the patient's educational level and age and calculate the corresponding Hong Kong Marker percentile. So with a percentile lower than 16, the patient is actually classified as mild neurocognitive disorder, and those is equal or less than second percentile is major neurocognitive disorder. And AD8 is a screening questionnaire with a score higher than 2, means that cognitive impairment is likely to present. And PHQ-9 is the depression screening questionnaire with a severity of depression scale as this table charted here. So up till now, we are recruiting 251 patients with a distribution of normal, mild, moderate, and severe profound hearing loss as shown in this table. And around 60% of our patients had bilateral hearing loss greater than 40 decibel that require amplification. And 40% had at least moderate bilateral hearing loss. And for the neurocognitive impairment, overall 18% of patients was found to have mild cognitive impairment, and 8% was found to have major neurocognitive disorder. And this table is basically showing the number of the patients that have different severity of hearing loss and their prospective neurocognitive impairment severity. And we could see that with a worse severity of hearing loss, there are more percentage of the patients that were screened to have at least MCI or major neurocognitive disorder. And I would like to focus the attention on the group of severe to profound hearing loss. So if the patient were found to have this severity of hearing loss, they have around 60% that was screened to have at least MCI and 14% having major neurocognitive disorder, which is quite significant. And indeed, we did find a significant correlation between hearing loss severity and a worse score of Hong Kong Marker percentile, which is significant with a Spearman rule of 0.19. And we also calculated the relative risk of at least MCI in different hearing loss severity. So if our patient have mild to moderate hearing loss, they have 1.1 times higher risk to develop MCI compared to the normal hearing patient. But if the patient have severe to profound hearing loss, the risk is increased up to 4 times. So it is actually compatible with the previous literature of the risk of dementia in different degrees of hearing loss. And as for AD8 score, we are unable to find a significant correlation between the score and the hearing loss severity, but it could be attributed to that the patients with dementia actually are not aware of the hearing loss themselves. As for depression, overall 49% of our patients were screened to have mild depression, and 5% of them that actually were screened to have moderate to severe depression that require psychiatric referral. But we are unable to find a significant correlation between hearing loss severity and depression. So obviously the limitation of the study is that it is a relative small sample size for an epidemiological study, but we are still ongoing recruiting more patients, and we're trying to find more staff to get help to recruit the patient, because initially we can't really interview all the patients walking in to the nursing clinic for a formal cognitive assessment due to the manpower limitation. And this study also cannot establish a causal relationship between hearing loss and dementia, and more importantly, whether hearing aid can actually modify the disease course. So it is also our vision to actually intercept the pathway from hearing loss to dementia, maybe through the prescription of hearing aid to see if hearing aid can actually slow down or reduce the rates of dementia development. And there is actually an ongoing RCT study by Professor Zhang that they randomized the patients to different groups, one groups with hearing aid prescription and another one without, and to see if their cognitive impairment have any difference. And we're expecting result maybe in 1 or 2 years later. So to conclude, we found a significant correlation between worse hearing loss and a more severe neurocognitive disorder, but we don't find a significant correlation between hearing loss and depression in our study. But we would like to call for attention that in our routine practice, when we are approaching patients with hearing loss, we should be having in mind that we should also try to screen for the presence of any dementia in elderly patients after knowing the fact that the worse hearing loss, the higher risk the patient is going to develop dementia. And we do recommend screening of dementia and also depression as part of the workup when we approach hearing loss, may be more possible with a nurse clinic model. So last, I would like to thank Professor Zhang and the research team for this opportunity, and also huge support from our cluster OPD and audiology department, and also Department of Psychiatry and Geriatrics for taking care of the patient who was screened to have depression or dementia. So this is the end of my presentation, and thank you very much for your attention. I welcome any questions.